Hello, everyone. A warm welcome to all of you, and particularly to our special guests, our panelists, and moderators. My name is Sergio Aguilar Gaxiola. I'm a professor at UC Davis Health and the director of the Center for Reducing Health Disparities and the Community Engagement Program of our Clinical and Translational Science Center. We are thrilled with the response we have received to this event. There are 805 registered for this session at the close of registration, and we are also broadcasting through YouTube. Once we complete all 3 sessions of this 3-part symposium, we will be writing and publishing a report based on the recommendations of our experts, and we'll make it available early next year. As a very brief background, on June 26th of this past year, our Center for Reducing Health Disparities, in collaboration with the UC Davis Office of Health Equity, Diversity and Inclusion, that Dr. Henry Tong leads, convened an all-day symposium entitled The Humanitarian Crisis at the US-Mexico Border, a deeper dive from diverse lenses, which was, to a great extent, the inspiration for this 3-part symposium. Today is the second of a 3-part series of the very relevant and timely topic of trauma-informed care and services for immigrant families. As I mentioned, the interest generated by this topic as measured by those registered has been remarkable, and we are thankful for that. I want to thank all of the people, many people that have contributed to bringing this event to you today. There was a lot of behind-the-scenes work and effort to make this possible. Thank you to our CRHD team. But before we begin, and I'm eager to start today's program, I want to review a few housekeeping items. Please be aware that we are recording this session. All attendees are muted and cannot use their cameras. These functions are limited to the speakers only. We have an interactive activity or brief polls. Please participate when the time comes for these polls. Closed captioning is active. If you have technical difficulties, please send a message in the Q&A function. Type both your questions and comments in the Zoom chat, and we encourage you all to use the chat function to connect with us and one another, and add resources you would like to share as well. If anyone is believed to misuse the chat function, you may be removed from the session. After this session, on our Center for Reducing Health Disparities website, we will post a recording to the session and the panelists' slide decks. The Q&As and resources will be added at a later time. Finally, please be advised that some content discussed and or shown in the session may be disturbing or upsetting. So let me very quickly allow me to review how we have organized today's session. We started by reviewing housekeeping items. We will move on to hear opening remarks. Then we have a special guest, and we'll have a moderated conversation with California Surgeon General to set the stage for today's session. This will be followed by panelists' presentations. Then we will take a quick break, during which time we will post an anonymous poll. After the break, we will have a moderated discussion with our panelists. Some of the topics and questions posted at the time of registration will be addressed during this discussion. This will be followed by an open Q&A session. This is your time as attendees to post questions for the speakers. Please use the chat function to pose questions. And we will end today's session with closing remarks. So with that, we are truly delighted to have Dr. David Lubarsky provide opening remarks. Dr. Lubarsky's bio is included in the program, so I'll be brief. Dr. Lubarsky is the Vice Chancellor of Human Health Sciences and Chief Executive Officer for UC Davis. He oversees UC Davis Health's academic, research, and clinical programs, including the School of Medicine, the Betty Arene Moore School of Nursing, the 1,000-member physician practice group, and the UC Davis Medical Center, which is a 625-bed acute care hospital. Since joining UC Davis Health 2 years ago, Dr. Lubarsky has re-energized the health system. He committed the organization to expanding care for the underserved, and with multiple strategic partners, he's furthering the UC Davis mission to make the world a better and healthier place. Our UC Davis Chancellor, May, calls Dr. Lubarsky a problem solver and a change maker. David?
Thank you so much for the warm introduction, Sergio. Working with people like you is truly a privilege, as it is the opportunity to speak to the audience here on Zoom. This is a really important topic for all of us, because the people on this call can actually make a difference in the lives of immigrants and their families, and they're counting on us. I also want to give a shout out to Sandra Hernandez, who is always supportive of these types of activities, and really appreciate that. The theme here touches on our core values at UC Davis Health. We're dedicated to building a healthier world where every single person in our community has an equal opportunity, not only to access healthcare, but to actually achieve good health outcomes when confronted with illness and to maintain their wellness. We're not doing quite as good a job as we should be, perhaps, but this type of conference is one step closer. Health equity for all, especially those who need it most, is a guiding principle for us now here at UC Davis Health. But there are some problems, specifically toxic stress, that can impact immigrant communities in a way that transcends the ability of just a healthcare system to fix. Among immigrants and immigrant families who often live a life of insecurity in terms of food, housing, healthcare, risks of deportation and family separation, as well as the xenophobic persecution under the current administration, we can induce long-lasting changes to health that are quite deleterious. These are called epigenetic changes that kind of alter how our DNA expresses itself, and that can last long after these traumatic stress episodes subside. This is especially true in children, and I know that Dr. Burke is on and knows probably more about this, certainly, than I do. But the problem when we induce this type of toxic stress and epigenetic changes in children is that they begin to be passed down to future generations, limiting their health and their success in ways that we don't fully understand yet. These toxic stress experiences that immigrants are subject to currently cause changes in our body chemistry that predispose to physical and mental health alterations. They predict problems in areas as diverse as the development of diabetes and serious mental health and behavioral health issues. To interrupt this cycle, we must address the basic economic needs. We must provide supportive, safe environments in addition to good health care that will in turn support a healthy mind and body development. Now, it's one thing to talk about these type of things, but I'm very proud that at UC Davis Health, we're actually trying to do something about it in a way that, frankly, is nation leading. Our Department of Pediatrics, in close partnership with the Sacramento County's Healthcare Services, are about to open a adverse childhood experience clinic. It's actually going to be called a CIRCLE clinic, the Comprehensive Integration of Resilience into Child Life Experiences, at the Sacramento County Primary Care Clinic at the corner of Broadway and Stockton with our attending physicians. I want to credit the leadership of not only our Department of Pediatrics chair, but also that of Katie Carlson, Bina Gogo, and Sumi Mishra, who are all heavily involved in this. And we're going to probably start, in order to better evaluate this, by trying to get all the foster children who are entering foster care in Sacramento County into this clinic when it opens, so we can really begin to understand how best to ameliorate adverse childhood events, which really permeate the existence of the foster care program, frankly. The idea is to provide comprehensive medical examinations and to have a longitudinal screening for mental health, and to make sure that we try and treat as many of these children as possible. And clearly, some of the findings that we're going to have will translate importantly to immigrant families as well. When there are incredible stresses on families, child-parent behavioral interactions suffer. And to that end, we also have a parent-child interaction therapy clinic that is trauma-focused and will also be open and offered to people who need it. And last but not least is the fact that all of this should result long-term in understanding more about toxic stress and reducing the incidence of children with toxic stress, whether it's in the immigrant community or the foster care community, in terms of juvenile delinquency and the very high rate of incarceration we see with foster care. We're very grateful for support for this initiative from Dave and Katie Carlson and the Dennis and Nancy Marks Foundation, as well as the School of Medicine, which are obviously, this is a labor of love, if you will. I'm going to stop there, but I just want to touch on some other things very briefly, is that the stress of being in the immigrant community has been nothing but compounded during this COVID-19 crisis. And that we have exposed worsening health disparities and in the ability to fight off COVID-19. And I believe this is related to what I was saying previously, which is that the constant fight and struggle for basic economic decency and for a supportive, safe environment and a feeling of security creates toxic stress in both adults and children. And when you have something on top of that, like a pandemic, I think what we're seeing is that people just are more susceptible to disease when they live in communities that are not well served. So we need to do more, and we need to reach out. And to that end, we have partnered with community groups such as La Familia on making sure there is more widespread testing in our underserved neighborhoods. But just again, testing is not the answer. Fixing the underlying problems are the answer. Fixing the underlying basic support of those communities is the answer. And making sure that we as health systems are doing our part to deliver enhanced access and more culturally sensitive, competent care in these communities. I'm going to stop there and turn it back over to you, Sergio, but thank you for the opportunity to speak here today.
Well, thank you so much, David, for your leadership and also for being so supportive of these topics. You have been steadfast in your support. So thank you so much.
Thank you.
Well, next, it is truly my sincere honor and privilege to introduce Dr. Sandra Hernandez. Dr. Hernandez's bio is also included in your program, but briefly, very briefly, Dr. Hernandez is president and CEO of the California Healthcare Foundation, which has supported this three-part series. And also, Sandra is a national, state, and local leader, recognized champion as well for improving access to care for underserved populations. Thank you, Sandra, for all the things that you do. Sandra?
Thank you, Sergio. Appreciate it very much. Very nice to be with everybody today. I also want to thank David for his remarks and for his leadership. He is indeed a problem solver. I want to add my welcome to everybody who is on the symposium today, and those of you who will be listening to us on YouTube, welcome. For those of you who don't know the California Healthcare Foundation, we are a statewide independent foundation who, as Sergio said, really spends the bulk of our resources focusing on how the healthcare delivery system can provide the best care that people need in California when they need it, with a very particular focus, of course, as Sergio said, on low-income communities and communities who have historically been disenfranchised, many of whom David spoke about a moment ago in his remarks. We know that historical and continued oppression and structural racism results in widespread inequities in our society. David talked a moment ago about COVID-19. There are countless examples of these inequities and how they manifest themselves in communities all over the country. Today, its conversation is both timely and highly relevant. We are in an environment where racism and xenophobia are maintained and intentionally exacerbated by a federal administration who, via executive orders and administrative policies, have created, in fact, a human rights crisis at the US southern border. Family separation, zero tolerance, public charge are but of a few of literally hundreds of executive orders that this administration has promulgated. And for those of you who would like to review those, our speaker at our first part of this symposium, Dimitri Papamitrio, he referenced the Migration Policy Institute's report, which details hundreds of these immigration executive actions that have been taken during the Trump presidency. These policies and their implementation and enforcement have created a toxic environment to immigrants, to their families, and to our communities. Today's part 2 session will focus on how the healthcare system and providers can deliver trauma-informed care to immigrant families and workers. Regardless of where you work, regardless of your place in society, whether you're a social worker, whether you're a clinician, whether you work in policy, whether you're an advocate, important for all of us to understand how our systems can and should be prepared to address toxic stress societally, culturally, and of course, with immigrant families themselves. The California Healthcare Foundation is incredibly proud to be a sponsor of this symposium. And really today's program is an exceptional lineup with our esteemed California Surgeon General, who's an expert in adverse childhood experiences, who you'll hear from momentarily, and really an esteemed panel. So I look forward to the entire conversation today, and we'll come back at the end and wrap up alongside with Sergio. So again, welcome. Thank you for all of you for joining us. Back to you, Sergio.
Thank you so much, Dr. Hernandez, Sandra, for not only the things that you do, but for making this three-part symposium possible.
Our pleasure.
And with this, it is truly my genuine pleasure and honor to introduce Dr. Nadine Burke-Harris, our first ever California Surgeon General. You may also have in your program her many international, national, and state accomplishments. Please read her bio. You will be inspired, as I am. Dr. Burke-Harris is an award-winning physician, researcher, and advocate dedicated to changing the way our society responds to one of the most serious, expensive, and widespread public health crises of our time. childhood trauma. As I mentioned, she was appointed as California's first ever Surgeon General by Governor Gavin Newsom back in January 2019. Dr. Burr Harris' career has been dedicated to serving vulnerable communities and combating the root causes of health disparities, something that Dr. Lubarsky emphasized. Drawing in research from the CDC and Kaiser Permanente, Dr. Burr Harris identified adverse childhood experiences, or ACEs, as a major risk factor affecting the health of her patients. In 2011, she founded the Center for Youth Wellness and subsequently grew the organization to be a national leader in the effort to advance pediatric medicine, raise public awareness, and transform the way society responds to children exposed to ACEs and toxic stress. She also founded and led the Bay Area Research Consortium on Toxic Stress and Health to advance scientific screening and treatment of toxic stress. Finally, her work has been profiled in best-selling books as well as in the film, which I had the honor to watch, at least a part of it. Resilience. Dr. Burr Harris has been featured on NPR, CNN, and Fox News, as well as in USA Today and the New York Times. Her TED Talk, and I would strongly recommend that you watch it if you haven't, How Childhood Trauma Affects Health Across the Lifetime, has been viewed more than 6 million times. And her book, The Deepest Well, Healing the Long-Term Effects of Childhood Adversity, was called indispensable by the New York Times. I'm truly honored that I will engage now in conversation with Dr. Burr Harris. A warm welcome to you, Dr. Harris. We are delighted with your participation. And
it's good to see you.
Good to see you again, yeah. There are so many topics that we would like to talk, but we have prepared some questions for you. Shall we start?
Sure.
All right. Well, the first question is, you are well known for highlighting the impact of adverse childhood events, or ACEs, as I just mentioned briefly, and toxic stress and trauma on children's health. Can you describe that impact on children's mental and physical health, both in the short term and over the lifetime of those children when they are adults? And this is of key relevance right now, given not only the pandemic, but also in California now with the fires as well.
Yes. Well, this is something that for me came out of my experience as a pediatrician caring for kids in a vulnerable community. And what I was seeing in my patients was that my patients who had, the most significant histories of adversity were also my patients who had not only some of the things that we would expect, like, trouble paying attention and learning in school, but also things like, very high rates of asthma or autoimmune disease or other health conditions. And I will tell you, I will never forget something that happened early in my career that really highlighted this connection between adversity and health. And I was sitting down with a patient who had asthma, and I was talking with her mom, and I was saying, okay, let's go over those asthma triggers one more time. What did we miss? Because we've been working on, all these other things. There's no pets, there's no, other asthma triggers. And I remember this mom said to me, doctora, I noticed that my daughter's asthma tends to act up every time her dad punches a hole in the wall. And really, that was one of the things that drove me to dive into looking at the science of how early adversity affects health and well-being. And it turns out that, you know, when we experience something scary or stressful, the body's natural biological response, the fight or flight response, gets activated. And that's great if it's once in a long while, and it's designed to save our lives from a mortal threat. And then it shuts itself off, right? So that stress response, it activates so many parts of our body, our brain, our blood pressure, our heart rate, right? Like if you think about all the things that you think about how you feel when we feel scared or stressed. But if that happens too often, the stress response is activated over and over and over again, and it goes from being adaptive or life-saving to maladaptive or health damaging. And so high doses of adversity, especially during the critical and sensitive periods of early childhood development, are associated with long-term changes to the structure and function of kids' developing brains, their developing immune system, hormonal systems, and even the way our DNA is read and transcribed. And that is what all of those changes are, what are now known by scientists as the toxic stress response. And that's what leads to increased risk of things like diabetes, asthma, heart disease, and stroke.
You know, one thing that I really love about how you, put it is that it is so relatable. I think that the audience can relate to the examples that you provide. And you are a great communicator. And I appreciate and I do thank you for sharing that information in a relatable manner. Okay, so
well,
go ahead, excuse me.
No, go ahead, please.
I'm gonna go to the second question, okay? In this symposium, we are trying to frame the experiences of immigrants, immigrant children, immigrant families, as another way that ACEs, toxic stress, and trauma are experienced. For example, that the detention and deportation of a parent has parallels to having a parent incarcerated. Could you please comment on this framing?
Yes, absolutely. So when we talk about the traditional ACEs, right, we look at the categories used by the CDC and Kaiser when they did the study. It includes physical, emotional, and sexual abuse, physical and emotional neglect, or growing up in a household where a parent was mentally ill, substance dependent, incarcerated, where there was parental separation or divorce, or domestic violence. So those are the 10 traditional criteria. And I think that immigration was one that they didn't necessarily think about at the time. But one of the things that I think is really important is that when we look at our community of immigrants, they represent a particularly high-risk population for several reasons. Number one, many immigrants are fleeing situations where they've been experiencing high doses of stress or adversity. So, for example, last year I testified before the Department of Homeland Security, talking about the Trump administration's policy of separating kids from their caregivers. And what we see is that for so many families, immigrants and refugees, they're leaving a very, very difficult situation, right? That's why they're leaving their homeland to begin with. But even for those who aren't fleeing a scary or dangerous situation, just the process of immigration, and I will have to say as an immigrant myself, the process of leaving home, leaving all of your relationships and your connections and your social connections and all of these things and moving to a new place, in and of itself it's a stressor, right? And so we recognize it's a stressor, and we recognize that when it comes to our body's biological response to stressors, is that when those those stressors are buffered by safe, stable, and nurturing relationships and environments, and particularly from a trusted caregiver, right? That reduces the biological impact of that stressor on our physiology. But when you look at something like a policy that separates children from their caregivers, right? You take families who may already be at high risk from whatever situation they're leaving. It's a stress, just the journey itself, the process of migration itself is a stressor. And then when they get here, the risk of then dramatically exacerbating the health risk. And I can't overstate this. Dramatically exacerbating the risk to brain development and to infection risk, to the immune system, to the hormonal system, goes profoundly up when you remove that capacity for buffering care. And that's what we see for many of our immigrant populations. But I would say even for our immigrant communities who don't experience any of that, still just the process of immigration, coming to a new place, leaving your trusted relationships, leaving your social networks, and then having to go through the process of reestablishing that is a time of vulnerability. And what we know for anyone experiencing this time of vulnerability is that the relationships and environments that they encounter make a really big difference in terms of outcomes. And so that's really something I think that it's important for all of us, both as healthcare providers and as policymakers, to keep in mind when we're looking at the immigrant experience.
Yeah, so thank you so much for that comprehensive response. And I'm an immigrant myself, and it resonates so much with my own experience and what I have learned through the years also in terms of the research that we are involved. Well, what can physicians and other healthcare providers do to become more aware of ACEs, toxic stress, and trauma?
I'm so glad you asked that question. So here in California, we've really recognized that adverse childhood experiences and toxic stress represent a public health crisis. And when we say a public health crisis, I mean it affects a lot of people. So across the US, we see that about 2/3 of our population have experienced at least one of the 10 traditional adverse childhood experiences. And anywhere between 13 and 17% have experienced 4 or more. Here in California, it's about 63% that have experienced 1, and a little over 17% that have experienced 4 or more. Mm-hmm. And so we have created an initiative called ACEs Aware. And it allows, and the initiative really focuses on training our healthcare providers to recognize and respond to adverse childhood experiences and toxic stress as risk factors for poor health, behavioral health, and social outcomes, and understand how to respond with trauma-informed care. And it's built on these really science-based principles that, number one, when we look at, last year, the National Academy of Sciences, Engineering, and Medicine released a consensus report. And in that consensus report, they talked about toxic stress as being a major risk factor for health challenges. And they recommended screening for adversity as a way of doing early detection and early intervention. Because what all of the research shows us is that early detection and early intervention improves outcomes. And what ACEs Aware is doing is really giving providers tools on how to screen for ACEs and how to respond with trauma-informed care, right? How to assess for toxic stress and how to respond with trauma-informed care. Here in California, providers can also get reimbursed. Our Medicaid providers can get reimbursed $29 per screening. And anyone can go to, any healthcare provider can go to the acesaware.org website, take the training for free, and get continuing medical education and maintenance of certification credit for doing so. And so we're encouraging all of our providers to do that. And I'm really pleased, since we launched the initiative in January of 2020, more than 13,000 providers have gone ahead and taken the training and have become ACEs aware. So we're really excited about that.
Yeah, that's great. Actually, you were ahead of me because I was about to ask you a follow-up question to that question, and that was if there are screening tools and clinical interventions that could be used, and certainly there are.
Yes, that's right. So there's one thing that I think it's really important to highlight, which is to dispel the myth that there are no interventions for addressing the toxic stress response. Right? So it turns out that there's actually quite a bit of data that show that things like regular exercise, balanced nutrition, mindfulness interventions, good old-fashioned mental health, right? Sleep, and I will say, probably most importantly, healthy relationships target all of the biological derangements of toxic stress. So they reduce stress hormones, they reduce inflammation, and they enhance neuroplasticity, right? So these are things, and when we're talking about these interventions, we're seeing data that these interventions can actually reverse some of the changes that we see to our epigenetic regulation, right? So our telomere erosion of our telomeres, the bumpers on the ends of our DNA. These interventions actually help to address the biological impact of toxic stress down to the molecular level.
Yep. Yes. No, thank you so much. Actually, one of our staff just posted the acesaware.org website, and I hope that our audience access those remarkable resources that you have posted and your team have posted as well. So there is another question. What are some individual, family, and community level responses that families experiencing trauma can do to mitigate these impacts and build resilience, healing, and wellness?
So there's a lot of stress going on right now, especially in the context of COVID-19. And one of the things that my office did was we actually made available the Surgeon General's playbook for stress management during COVID-19. It's available at covid19.ca.gov. But the strategies and interventions that we highlight are really based on the research on what helps to regulate the biological stress response. So again, as I mentioned, healthy relationships, right? Maintaining our social connection, even during a time where we have to be physically distant, is so critically important. Regular exercise, I can't say enough how much that helps to regulate the stress response, release healthy hormones, and metabolize the stress hormones. But also, mental and behavioral health care, I think, is critically important. Oftentimes, I think that we recognize the importance of our regular health care, but the body doesn't stop at the neck, right? So it really addressing our mental and behavioral health and even preventively, I think is really important. thinking about what it looks like to maintain our wellness, right? Our mental and emotional wellness, I think is really critically important.
Yeah. By the way, I just looked quickly to the chat and I saw that from Sheila James from the Office of Minority Health, you know, out of DHHS Region 9. You know, she is one of the leaders in that organization, that she says the Surgeon General's playbook is a great resource. I had shared it with many organizations. Thank you, Sheila, for your comment. That's great. So you mentioned the ACEs aware, and you also mentioned the stress busting playbook. Are there any other resources available that you would like to share?
Yeah, one thing I want to highlight is that within the ACEs Aware website, there are quite a number of resources for providers and others who are interested in doing this work. In addition, the CDC has launched a pretty big initiative to raise awareness about ACEs and toxic stress. So I think those of us who are public health nerds will know that the CDC releases something called the MMWR. It's the Morbidity and Mortality Weekly Report. And in November of last year, the CDC actually dedicated an issue of the MMWR to adverse childhood experiences and toxic stress. And so for public health people, that's like getting the cover of Vogue. Like, it's a big deal. And so there are excellent resources on the CDC website. And so yes, that would be another resource as well.
Wonderful. How about CalHope?
Yes. Oh my goodness. Thank you. Thank you. So CalHope is another resource for mental health and behavioral wellness resources. It's created by our Department of Healthcare Services. And so folks can go to the CalHope website. I don't have it off of I think it's calhope.org or calhope.ca.gov. I don't remember, but I can look it up and put it in the chat. But it is, that's a great resource. And I want to highlight that California's covid19.ca.gov website has a whole page on emotional well-being. So for anyone who is struggling or needs access to resources, under the emotional well-being page of covid19.ca.gov, there's quite a few resources there.
Yeah, do you know the beauty about this interactive, session is that the audience is posting exactly what, CalHope, they are posting resources from other agencies, in Spanish, some of them. So it is just terrific, I really thank you, because you are triggering a lot of these responses that are being shared right now, and that we will be sharing, as I said at the beginning of this session, a little bit down the road.
And one thing I want to, sorry, I don't mean to interrupt, but one thing I want to highlight is that all of the resources on covid19.ca.gov, including the Surgeon General's playbook on stress relief, están también disponibles en español.
Excelente. Excelente. I'm on the same club, by the way, that you just mentioned, the nerd, public health nerds. So it resonates with me. Yeah, I have a question. Is one thing that I have known you to be a advocate for is the importance of resiliency. Can you just say a few words about that?
Yes, absolutely. I think that especially now when our families and communities are experiencing so many stressors and challenges, there are a couple of things that I find to be really exciting. So in the there are a couple of pieces in terms of, number one, I think having a level of self-compassion and giving ourselves a break. I think one of the pieces of the science and the research about ACEs and toxic stress that is so important is that it allows people to recognize, wait a minute, you know what? My body is just having a normal reaction for all of the things that I've been going through. But the thing that I find most exciting about this work is the fact that what the science also shows us is that when we do have things like safe, stable, and nurturing relationships and environments, when we do have these connections, and when we practice this self-care, and when we care for each other, that it actually makes a profound difference in terms of our health. And that piece of resilience, that science of resilience, shows, for example, that kids who actually there was a research study showing that kids who were institutionalized, who were in essentially foster care, and this was an international study, who were randomized into high quality nurturing caregiving, that they actually showed normalization of the white matter structures of their brain. So when they did MRIs, they saw that the effect of this nurturing care was healing of the developmental trajectory of the brain. Is so powerful, right? It's so incredible to see that. And I think that the message there that I want to send out for children, for families, for parents, for caregivers, for individuals, is that we do have the power to heal. We have the power to heal ourselves and each other. And I think understanding that is critically important.
Well, that's remarkable. And actually, this is a treat, certainly for me, and I'm sure that for the audience as well. And it sets the tone for the rest of this session, but for the rest of also the rest of the symposium. So a heartfelt thank you to you and to your staff, your team, who were fantastic in helping, get us to this moment. And thank you for all you do. We greatly appreciate it.
Well, thank you for having me. Thank you for hosting this important conversation and for the incredible work that you do every day. Very grateful to have the opportunity to be a part of this conversation.
You make us all proud. Absolutely. Okay, so now I'm going to change a little bit of gears, but continuing with the session. And now I'm truly delighted to introduce to you Ignatius Bao, our moderator for today's fantastic panel. Ignatius is an independent consultant working with funders, health departments, and community-based organizations on both immigration and health policy issues. He worked for 10 years as an immigration attorney at the Lawyers Committee for Civil Rights of the San Francisco Bay Area and was the founding board chairperson of the Northern California Coalition for Immigrant and Refugee Rights. He helped draft the 1989 San Francisco City of Refuge, or Sanctuary Ordinance, and was on the statewide steering committee of Californians United against Proposition 187. Some of us remember what that proposition caused to the immigrant population in California at that time. when it was released. Ignatius will moderate our excellent panel for our session today. Ignatius?
Thank you, Dr. Aguilar-Gaxiola, and welcome again to folks who have joined us. We're really excited to engage in a continued conversation. Dr. Burke-Harris really, I think, set us up on this framing of understanding the experience, not just of immigrants and refugees that we may see in the headlines, those that had families separated, those that are being denied some really basic rights, but really just the ordinary experience of immigrants and refugees every day as we welcome them into this country, as those of us who identify as immigrants and refugees ourselves can also relate to that experience. And so to start us off, we're going to share a video. The video could be a little bit disturbing because it's real life. It is about a family that has been facing this kind of trauma because of the threat of detention and deportation. And we're grateful for Fostering Media Connections for documenting this and sharing this. This is from 2017.
That was a casual Tuesday morning where we were just getting ready to go to school like we always do. We were on our way to drop me off when we took a right turn and the lights flashed. First we thought it was police, but as he went forward, he automatically knew it was ICE, and they approached the car and they asked my dad what was his name, and my dad asked them what he had done wrong for him to stop him, and they told him to be quiet and to get off the car because he has an order deportation. I was feeling scared and sad because I'd never imagined experiencing something like that in my life, and because I've never been separated from my dad like that, and I thought I was never gonna get to see my dad again. It's been really hard for me. Sometimes I just feel like tearing up and just bursting into tears, but I know I have to be strong for him and for myself and for my family.
We never want them to just sit there and think about the situation. They're still really, really young and in a very delicate stage in their life.
He's in Adelanto, California in a detention center. So I was nervous to go see him, but once I got there, I felt happy that I got to see him and that he's still here. But the hardest thing is leaving there because like you can't bring your dad with us, and it's just a door separating. It's hard seeing him in that place because I know he's suffering and he's getting a lot skinnier. Now that he's gone, we have to do things to help keep my dad here and to help raise money for my family.
We're trying to share the responsibilities that my dad used to do, which it also stops us from a lot. I wanted to get back to school and I wanted to continue with the whole medical field. I wanted to get higher, and that's gonna have to be on hold now until hopefully my dad gets out.
My dad is not a criminal. He's a hard worker and does everything he can for his family.
It's difficult because he would always cheer me on and he would take me to the games, and now that I don't have him, it's hard because he's not there with me.
I hope that, first of all, no other family gets to experience this, for this law to stop. No paper should determine whether you get to stay here or not. We're all human. We all have bones and stuff. So, yeah, and I would hope my dad to be back with us in our house.
So thank you for, again, our colleagues at the Fostering Media Connections for sharing the video. The good news is this incident occurred in 2017, and I'm happy to report that a couple months later, with legal assistance, the father was released and able to begin the fight against that deportation order, and the family was reunited. But I think it really helps to frame the real life experience in these kinds of situations where the kind of trauma being experienced by the family is very real. So turning to our panelists now, I want to welcome our first panelist, Dr. Andres Felipe Sciola, who's a professor of clinical psychiatry at the University of California, Davis. He also is a co-director of the Restart program, which is the Resilience, Education, and Supportive Tools for Adults Recovering from Trauma program at the UC Davis Behavioral Health Center. Dr. Sciola.
Thank you, Ignatius. Good afternoon, everyone. I'm actually still touched and reverberating from the video that we just watched. I found it quite moving, and also I'm quite relieved to hear the good news at the end. So today I will be talking to you about trauma-informed care and resilience in working with immigrant families to address their mental health needs. So I appreciate everybody being here and inviting me to address these important issues. And I'm especially honored to follow on the footsteps of Dr. Aguilar Gaxiola in his dialogue with our Surgeon General, Nadine Burke-Harris. So I'm showing you here a model of trauma-informed care developed by Sheila Raja from University of Illinois at Chicago. And the most important point that I would like to highlight here in her model of trauma-informed care, represented by this pyramid, is that the base of the pyramid is what she calls trauma universal precautions, based on patient-centered communication skills and understanding the health effects of trauma, something that we've been discussing a lot this morning or this afternoon. And so borrowing from the universal precautions that were developed in the 80s because of the AIDS HIV epidemic, the idea is that anyone who comes through the doors of our agency or clinic or hospital or any setting can have a history of trauma exposure. So we don't need to ask necessarily, and you can see that the top of the pyramid is the screening, the red triangle there. So you don't need to ask to assume that someone may be exposed to trauma and act accordingly. Act accordingly means many things, but of course, the patient-centered communication skills, but also modifying, as we will see in the next slide, some features of your system. So a different issue that I think is important highlighted in this pyramid is the understanding your own history. And we'll talk more about that, echoing what Dr. Burke-Harris already said about self-compassion and self-care. So the Substance Abuse Mental Health Service Administration has the most popular, widely known definition of trauma-informed care as a provider, program, organization, or system that realizes, recognizes, responds, and resists. The 4 R's. The first 2 are mostly centered on knowledge of individual providers. So realizing the widespread impact of trauma, understanding potential paths of recovery, but also recognizing the signs of symptoms of trauma. And I will let you share with you some information later about that. And the second 2 R's are more centered on things that the system can do, such as changing policy procedures and practices to resist re-traumatization. So the SAMHSA also has 6 principles of trauma-informed care. And I don't need to emphasize enough here that safety, the first principle, has to be paramount in the care for immigrants and refugees, and think what for them means safety. It's also important to think that trustworthiness and transparency might be something that many of our clients and patients from this population may have specific barriers because of their trauma history to learn to trust. And so the importance of transparency is very prominent. Likewise, collaboration and mutuality, empowerment, voice and choice. And the number 6 here, is basically about what we call intersectionality. The fact that many of the cultural, historical, gender, race, and other social groups can interact in their vulnerability as well as their resilience in regards to trauma. I would like to add also to these principles that are not officially in SAMHSA, but by the way of listing this principle, building on strengths, enhancing resilience. You've heard already about this, but I believe it's very important when we talk about trauma to simultaneously talk about resilience. And one last encapsulation of trauma-informed care in this quote, very well known for many of you, I'm sure. Our program director said it best when he observed that we had stopped asking the fundamental question, what's wrong with you, and change it to what's happened to you. And in this, we can see that there's a shift, very critical shift between judgment and detachment of what's wrong with you, the usual clinical approach, especially in medicine, when we focus on symptoms and problems, to the curiosity and compassion stance that is implied in the question, what has happened to you? Now, when we talk about what has happened to you, we need to make a distinction between the big T traumas and the so-called little t traumas. We often think of trauma as things like a tragic death, an accident, a deportation, such as the one depicted in the video we just watched. Those are big T traumas, and we cannot miss them. But I submit to you that those big T traumas are really the tip of an iceberg. If we think of an iceberg as the biggest portion of it submerged underwater, those are represented in this metaphor with the little t traumas, which are much more common. Now, some examples, there are many more, but examples of little t traumas that we don't think of are structural stigma. And I will tell you a little bit more about structural stigma in a second, stemming from the intersecting isms like racism and phobias such as homophobia. Government-sponsored displacement, seclusion, and segregation, which has a sorry and sad and long history in this country. Public charge rule and DACA rescission, or the threat of rescission. Laws that don't protect same-sex couples. In addition to that, we have macro and microaggressions based on race, ethnicity, national origin, social class, gender expression, sexual orientation, or religion, among many others. So the importance of considering both types of traumas together is because stress response is the same. Regardless of the type of T trauma, you have a stress response that is triggered in what is also called stigma. So sociologists talk about 3 levels of stigma, starting with individual. When we internalize, for example, the fact that something is, many of you may be familiar with the literature on stereotype threat, when we activate certain biases that society and culture are giving us, what could be gender or race or religion, the interpersonal regarding that we were describing before, such as microaggressions, and then the structural represented by cultural values, state policies, institutional practices, laws, etc. And these all trigger a stress response. So in this busy slide, I want to walk you briefly to summarize part of the literature, the research on what is called biological embedding of stress given by little t or big T traumas. On the left, you have the early life stress, and on the right, we have, actually, I want to focus on the two brains, if you will, on the right and the left, that are representing the most important brain outcomes of early life stress. The elevated corticoamygdala threat sensitivity. In plain English, this means that the rational brain, the brain that allows us to make distinctions between the different things that, and logical things that allow us to navigate the world, and the emotional brain represented by the amygdala. So that connection is shifted in early life stress. And on the right hand, you have another image of a brain highlighted, a second change in which the connection of the prefrontal cortex, the rational brain, that can inhibit the threat sensitivity of deeper structures in the brain is weakened. So the combination of these two effects of early life stress leads to a cascade of hormonal and chemical changes in the body that is represented in the center by these low-grade inflammation. So the production, the overproduction of these chemicals that are associated with inflammation called cytokines that are responsible for the increased prevalence of physical and mental illnesses in those exposed to trauma. Now, is stress ever good? Indeed, there's positive stress, and I will not go into too much detail, but I want to tell you that on the right, there's toxic stress, that examples such as physical or emotional abuse, in which there's not an adult present, a caregiver that is reliable and committed to the wellness of the child. So we've talked already how Dr. Burke-Harris again highlighted some of the stress, some of the research that has shown that toxic stress can become tolerable or even positive, and we can reverse those effects when there is the presence of a committed adult in the lives of children. In fact, this dovetails with another field of research that is post-traumatic growth, PTG. You can see here in this graph how as the time progresses and the level of functioning after a traumatic event, people can succumb to the trauma and develop PTSD, but also they can recover and go back to their baseline, which we call resilience. And on the top line, we have someone thriving, that is to say, they achieve an even better level of functioning after trauma. So I will tell you, I'm actually going to skip this slide for the sake of time, because this is a complicated concept of resilience. What I want to emphasize with this picture is that we're not talking about individual resilience. And in the next slide, I want to make this complex concept of resilience as concentric circles overlapping, in which these different domains of individual, household, family, neighborhood, community, and societal resilience interconnect, and they can detract from each other. So in summary, what can mental health providers do for immigrants and their families from a perspective of trauma-informed care? First and foremost, we need to learn how to have trauma-informed conversations about exposure to adversity. And I say conversations because it doesn't need to be a screening or checklist. And this has to encompass not only individual adversities, but also community level across development and generations, including history. Second, identify goals and strengths that are important, relevant to our individual clients and communities and families. Then build and sustain interdisciplinary teams that can be very helpful when it comes to integrate and coordinate those mental health services to other needs such as physical health, socioeconomic, educational, occupational, or legal. So how can health providers, other health providers, identify and respond to mental health needs of their immigrant patients? So I think, once again, going back to Sheila Raja's model, implement trauma universal precautions, recognize unapparent manifestations of exposure. And these can include, for children, something like ADHD. For adults, could be somatic presentations, so we need to be familiar with those presentations. And educate patients. We can all do this, providers, educate patients on the signs of resilience and adversity. Identify resources to mitigate negative social and structural determinants of health. And in the last slide, I want to emphasize basically the same things that teachers, social service providers, and family members can do to support trauma-informed approaches for immigrants and their families. I want to be mindful of the time, and I know that we'll have time to ask questions, so I'm going to stop here. Thank you.
Thank you so much, Dr. Sheila. So our next panelist is Dr. Tu Quach, who is the Chief Deputy of Administration at Asian Health Services, which is a community health center in Oakland, California. Dr. Quach is an epidemiologist, well known for her work in Vietnamese nail salons and creating the California Healthy Nail Salon Collaborative. And she's also been actively involved in creating and driving One Nation, which is a coalition of over 100 organizations that have been organizing in the Asian American and Pacific Islander communities against the public charge regulation. So Dr. Quach.
Thank you, Ignatius. Hello, everyone. Thank you for the opportunity to share some of the work at Asian Health Services. As Ignatius said, Asian Health Services is a federally qualified community health center started in 1974. We are really rooted in the communities that we serve, and we've become a trusted source for information. We actually have, we provide medical, dental, and behavioral health, as well as a whole host of other services to about 50,000 patients. And we do so in English and 14 different Asian languages. And during this period of COVID, which I'll be talking about, we really try to respond to this pandemic and be rooted in the communities that we serve. This is a slide that just shows you the languages, the Asian languages that that our patients speak. And as you can see, that while the Chinese Cantonese speaking population is by far the largest, in no way does that take away from the smaller communities that we serve and the different languages that are needed. With each language comes with it different experiences, different needs, different historical and current trauma. I would say that as a Vietnamese refugee myself who came here as a child, it may seem like I have similar experiences to other Southeast Asian refugees, but my experiences is so different from the Cambodians and the Mien and the Laotians that came here. So it's really with that lens that we try to provide for the diverse communities that we serve. Unfortunately, when the pandemic hit, I would say that it was a perfect storm of so many issues that came up. That years before that, we were organizing at Asian Health Services and with our partners through One Nation and working with others across the nation, the fight against public charge, which was targeting at that time individuals who were seeking lawful permanent residence and penalizing them for using basic services like healthcare, food assistance, and housing assistance, something that many of us have depended on in the past and have returned back to this nation. That rule, unfortunately, even though we tried to block it in the courts, got implemented on February 24th, right before the explosion of the pandemic. And then with that, you had all of these anti-Asian attacks that were going on, blaming of Chinese and Asian Americans for the virus. And then all of the impacts that came with it, Chinatown, Oakland Chinatown, where Asian Health Services is located, as well as across Alameda. We were seeing restaurants close down, people being discriminated. Asian Americans were wearing masks, which was very common in Asian countries and in our communities, but being targeted and blamed for doing so. And then in the beginning of the pandemic, we all suffered from the lack of testing and PPEs. But in our communities, we were also experiencing it firsthand and trying to figure out how to respond. And like many other communities, the economic challenges and unemployment were really rampant. All to say that Asian Americans went underground. And I wanted to clarify here that I use Asian Americans and Pacific Islanders, but in this presentation, I mostly share about the experiences of Asian Americans. I want to acknowledge that the experiences of Pacific Islanders are very different, and I hope that there'll be an expert to speak about that. So for Asian Health Services, we had to make rapid and radical transformation overnight, literally overnight. That we saw that our visit numbers went down to less than 10% at that period. And we knew that for the safety of the patients and of our staff, we had to arrange for work from home, arrange for telehealth so that we can keep the care of our patients first and foremost in mind. So that required us to make a lot of changes, especially dealing with a community with a lot of language barriers, as well as the digital divide. It was huge for us. And we're happy to say that across our medical, dental, and mental health, we were able to rapidly bring back our visits to 80 to 90% of the volume that was through telehealth. And I just want to point out the picture that you see on the lower right hand. That is our 95-year-old patient. She would never have thought that she would go on video to speak to her doctor, Dr. George Lee, our CMO at the time. But we got her on. And this is the kind of work that our community health centers do. We respond rapidly and we are there for our community. Despite what we did, there was a narrative that was being framed around us, one that is being blamed and yet being invisible when it came to the needs. This is data pulled from Alameda County. And of course, it reflects the different case rates in numbers. And you can see there that for Asian Americans, our rates, case rates for COVID was the lowest when compared to the other populations. And that is not in any way to take away from all of the disparities that were experienced by the other populations. However, if you look at the same graph, but for testing rates by race ethnicity, you can also see that Asian Americans have the lowest testing rate. That is a problem that while others are getting tested, our communities were not coming forward to get tested. And we wanted to understand why that was. We were hearing so many of our stories from our own patients about the fear, the stigma, and not knowing where to get tested. We had talked to hundreds and hundreds of patients, and we knew this is a problem. At the same time, our colleagues at UCSF and other researchers were showing emerging data that highlighted that Asian Americans, among those who are COVID positive cases, they had a higher death to case ratio, what we call a case fatality. And you can see that this was happening in certain parts of California, like San Francisco, Los Angeles, and Santa Clara, throughout California, as well as in other states, that when compared to the overall case fatality, Asians really stood out. Yet we weren't seeing a lot of this highlighted as a disparity for our population. At the same time, we heard about the rising hate crimes targeting Asian Americans, blaming them. So many stories that were shared. This just shows you some of the reports that were coming out from the FBI and from others. But at the same time, there were many, many incidents that were not reported. I think earlier you heard about the iceberg of some of the crimes and the trauma that were being experienced, but imagine all those that were underneath that. So much that was not reported, not shared for fear, for stigma and everything else, and language barriers too. So at Asian Health Services, we decided to step up, and I led a team to conduct our own survey. We knew that these things were happening, but it was important for us to document it. So I set out to do a survey, and I was hoping for 500 people within 2 months. It's very fortunate that, given our reputation in the community, we were able to get over 1,300 people to participate, most of them being our own patients. This is just a demographic profile of the participants. And as you can see that the vast majority were Chinese, self-identified Chinese, with some Vietnamese in there, as well as other Asian American groups. Over half of them consider themselves not fluent. 80% of them are foreign born, and a majority of them live in the Alameda County, which is where our health center serves our many residents here. We got some questions, and I want to thank the California Health Interview Survey, CHIS, and Dr. Ninette Ponce for sharing some of her questions with us. So we started asking questions around who was getting tested. We found that in this sample, only 3% had said that they had gone tested, with a very small amount that reported a positive test, a very small sample. And when we asked why they didn't get tested, we found that 49% of them said that they could not find a place to get tested. And about 44% of them didn't think they had been exposed. At the same time, we saw that 36% of them had lost their regular job, and about a quarter of them had reduced hours. And this also shows you all of the economic challenges that were being faced by this population. We talked about anti-Asian hate, and when we asked the participants, survey participants, 6% of them reported that they had experienced some form of anti-hate, whether it was verbal or physical. And this range in age from 16 to 74. I pulled some quotes here, but I can say that through our staff and in talking to patients, we've heard a lot about physical abuse as well. When asked about mental health issues, 25% said that they actually experienced depression, and about 75% of them said that they are stressed. Only 5% of them had talked to their doctor or a mental health professional. Now, based on the literature for Asian Americans, to say that when a quarter of the population or of the sample says that they're depressed, that's saying a lot, because oftentimes Asian Americans do not report mental health issues as often as other groups. And when we asked about what they were doing to avoid getting infected, 73% of them said they avoided leaving the house entirely. And about 8% of them avoid going to healthcare, and 19% of them avoided public transportation. We asked about wearing masks because we knew that was very common but very important behavior. And 40% of them were wearing masks before shelter in place. 41% said that they wore it before, when shelter in place happened, but before it was required. And then the rest is usually by the time the government required it. So all of this was very interesting information for us and confirmed what we knew. So we had set out to have more of a comprehensive response, that we understand that in order to get people out tested, we had to have outreach and education that considered all of the different cultural nuances and language barriers, as well as the trauma that they were experiencing. And from once we got to testing, we can build out to contact tracing and really getting them to the case management and support that we knew our community needed. Next slide. Oh, I think you missed a slide. Okay. So we were happy to say that last week we were able to launch the first Asian multilingual, multicultural testing site open to the community. We are testing about 200 individuals per day. It's free regardless of insurance and immigration status, but really having the language support there. I want to point you to the picture on the right. The young lady standing in that white suit is Tiffany Kwan, our newly minted nurse practitioner. She had been working at Asian Health Services since 2013, first as a front desk receptionist, then went on to be a medical assistant, then went on to become a nurse, and then recently just got her nurse practitioner degree. And she is our swabber doing the test. She speaks Cantonese and Mandarin. She knows the community. So it's really not just about the testing, but having the people from the community serve the communities as well. In addition, we launched a COVID helpline. staffed by our own bilingual and bicultural staff who know the community, can schedule the appointments, can help them with results, but really doing case management, referring them to mental health specialists, and really collecting the resources and connecting them to the resources as needed. So really understanding that it's more than just the testing, but all of the services that are needed for our community who for so long had been overlooked. Our next step is to really get into case investigation and contact tracing and working with our county. It's really important that as a trusted healthcare provider, that we're the ones working to call our community, understanding the fear, the stigma, and the trauma that they experience, and being able to explain to them the importance of prevention and also linking them up to the resources that they need. This is a listing of the 14 CBOs that we work with. And lastly, I want to end with the last piece, which is our challenge and goal at this time was to prevent from being simultaneously blamed and overlooked for COVID-19. So with that, I'll turn it back to Ignatius.
Thank you, Dr. Klatch. So our final panelist is Dr. Altaf Sadi. Dr. Sadi is a neurologist at Massachusetts General Hospital in Boston. She's also an instructor in neurology at Harvard Medical School and the associate director of the Massachusetts General Hospital Asylum Clinic. And we welcome Dr. Sadi.
Good afternoon, everyone, and thank you for the opportunity to speak at this symposium, which has been so great, and I have learned so much just from the previous speakers. So really delighted to be here. I'm gonna just dive right in and sort of focus in on what health systems can do to provide trauma-informed care for immigrant patients. So as a clinician, my starting point is always the patient, and I want to begin by discussing a patient I saw in early March. So one of the sites that I see patients serves a predominantly immigrant population in a city where 1 in 3 residents identify as Hispanic or Latinx. And this was back in March. This woman that I saw was pregnant. She was experiencing debilitating headaches, so much so that she had gone to the emergency department a few months before. And between that initial visit and when she came to see me, her chart was filled with multiple notations of her not showing up for appointments. And when I asked her about her headaches, I found out that she was a survivor of intimate partner violence and applying for asylum. At this point, I asked her if I could refer her to the medical legal partnership that exists in our health center. And she said no. I pressed and she kept saying no. And eventually she shared that she did not want to get government help because of the public charge rule. So to be clear, the Trump administration's new public charge rule can deny green cards to immigrants perceived as dependent on public services like Medicaid. But this public charge would not have applied to her because it doesn't apply to asylum seekers. And this medical legal service is not a government service. It was something that's offered by our medical or clinic alone. So but she remained really, really scared. Her story is a good starting point for 2 reasons. So one is that her experience is supported by so many studies that have shown over and over again how policies of exclusion as well as perceptions of exclusion are linked to both emotional and physical health outcomes for immigrant patients. In addition to increased anxiety and worsening health that has already been discussed in this presentation and earlier talks, studies have shown that fears of deportation is associated with increased markers of inflammation and increased cardiovascular risk factors like high blood pressure. And then when the 2016 US presidential elections happened, researchers began to identify association between Trump's election and decreased health-seeking behaviors and worsening health for immigrants and their families, especially among Latinos in the United States, irrespective of immigration status, as measured by preterm births of US Latina women, avoidance of healthcare, and increase in traumatic experiences and mental health conditions, including in children and adolescents. The second reason why I started with the patient story was because it shows how offering immigration-informed care goes hand in hand with offering trauma-informed care. So as it's already been alluded to, these individuals are facing sort of pre-migratory trauma from their native countries, trauma from the migratory experience, and trauma that occurs in the post-migration context that may or may not involve detention. So this is a figure from a model my colleagues and I, including Dr. Patler, who's at UC Davis, proposed, which we call the Immigration Intercept model, that borrows from the Justice Intercept model that it's used to identify community interventions for people moving through the criminal justice system that we had adapted. And I think it's a helpful frame to think about the totality of potential trauma someone could experience, including for the patient whose story I began with. So this policy climate of increased immigration enforcement and increased anti-immigrant rhetoric led to my research question, which was, what can healthcare facilities do? And the product of our research is now publicly available as a toolkit in YouTube videos and in academic publications. And I'll show you a brief segment of the introductory video just to set the stage.
Hi there, I'm Dr. Altaf Sadi. I'm a doctor and researcher passionate about immigrant health. For the past 2 years, and documenting the relationship between the needs of immigrant patients and what clinicians and institutions can do to meet those needs. Immigrants have been under attack since the 2016 presidential election and its aftermath. During this time, clinicians and health systems across the country started noticing immigrant patients were changing how they access healthcare. On one hand, not showing up to visits or being afraid that accessing care could jeopardize them in some way. On the other, coming in with more anxiety and mental health issues from their increased worries. So healthcare facilities and clinicians began implementing new policies and programs because their goal is to care about your health, not your immigration status. For my research, I became interested in understanding what specifically these new policies and programs were, so that hospitals and clinics nationwide could replicate these same actions, with the hope of protecting and welcoming immigrant patients in the healthcare setting. After interviewing 40 people across 5 states, I broke down these actions into 3 categories. What could be done at the institutional level, provider level, and the patient level. Make sure to check.
And we'll stop there, but I encourage you to check out sort of the videos and the toolkit on the website. But essentially, to summarize, and I'm here as for the academic publication, sort of adjusted from 3 categories to 5 major domains, and I'll just go through them very briefly. So one category of risk reduction strategies that can happen in the healthcare system or clinic that you might be practicing in is thinking about ways to reduce the risk of immigration enforcement on or near facilities. So this might include designating public and private spaces that limit where immigration enforcement may or may not be able to go without a valid warrant signed by a judge. The second category is concerns around immigration status related information disclosure. So that includes thinking about how, if at all, information about immigration status is acquired or documented in medical records. One category is thinking about risks associated with patient level stressors. So primarily those are legal stressors and thinking about ways to address them. But at the same time, thinking about resiliency promotion as a component. So poor health outcomes are associated with stress and worsened when events are perceived as uncontrollable. So providing patients with tools and resources is really critical here. The fourth category is addressing stressors among health personnel. So nationwide, nearly 1 in 5 healthcare workers are immigrants, and thinking about them needs to be part of the solution. And lastly, thinking about coordinating risk mitigation, either through having a designated point person or task force that's at your facility charged with addressing this very evolving and very complex space that is the intersection of healthcare and immigration policy. I'm going to show a segment of another video just so you guys can get a flavor of specifically how this operationalizes on the ground.
Patient level. I found found that there were 6 common actions healthcare facilities were taking at the patient level. Here they are in no particular order. 1. Educating patients about legal rights. Whether by using community health workers, community-based immigrant organizations, or just having Know Your Rights cards in waiting rooms or clinic exam rooms, the same way there are pamphlets about diabetes or hypertension. 2. Pursuing collaboration with trusted legal partners. Whether through a formal medical legal partnership, which is having a lawyer embedded in the healthcare team to refer patients to who have legal immigration issues, or increasing access to them through resource fairs or resource guides. Many immigrants can get caught up in fraudulent legal schemes, so knowing trusted local legal sources is very helpful. 3. Promoting affirming care messages to express to all patients that they are welcome. Best practices depend on the local context, like whether this should take the form of a poster or be disseminated using social media, radio, or television advertisements. Using sanctuary language can be ambiguous and falsely reassuring, or have different meanings in other languages. So steering clear of this language avoids confusion or providing false reassurance. 4. Incorporating deportation preparedness into larger emergency preparedness planning. This includes having parents identify alternative adult guardians to avoid foster care or compiling medical information for the patient and family members. Many community and legal organizations have checklists for this, so there's no need to reinvent the wheel. In parts of the country where there are concerns for hurricanes or other natural disasters, it is good to identify which services are available regardless of immigration status, all just to plan ahead. 5. Finding ways to nurture immigrant community empowerment and engagement. Examples like community advisory boards, youth and peer support programs, media or advocacy training, or get out the vote campaigns. Connecting with community-based organizations can be helpful here too, so it's good to invest in these community partnerships. 6. Pursuing alternative models for providing healthcare services. Telemedicine services, so patients can have video sessions with clinicians if they're too afraid to show up to clinic, or out-of-pocket payment plans for those who might have concerns about enrolling in public benefit programs like Medicaid. With effective planning, strong leadership, and a concerted effort to support the immigrant communities that have been targeted in this environment, we can advance a healthcare system that effectively serves all patients equally and promotes positive health outcomes for everyone. Make sure to check out our
And so in addition to the videos, we have a toolkit that sort of goes through the other policies in detail as well. But obviously this was the backdrop, right? And then COVID-19 hit and everything transitioned. And as you know, a lot of immigrant communities nationwide were impacted disproportionately. I think I heard it best described by someone who said the immigrant communities were quote unquote both essential and exposed. So I want to go back to my clinical practice again to describe how I saw this impacting patients. And of course, we had a rapid shift to telehealth services, but many of my patients are low income, without broadband internet access, or have limited English proficiency and struggled with navigating digital platforms that were created with English speakers in mind. And for the undocumented immigrants in particular, there was fear of privacy and security risk, where they didn't know who had access to Zoom when we were doing televisits, or didn't know if there was if our telephone conversation was being recorded or if the information was being shared. I had many patients who declined to sign up for our patient portal despite my pushing, and the reason didn't become clear to me until I had a patient who very eagerly joined. And then I sort of was trying to figure out why, and he said, "Oh, of course, doctor, I'll sign up. I don't have to worry about anything because I have my papers." And I think his comment really captured sort of the reverse of the fear that many of my patients had about accessing some of these new services we were pushing that we might otherwise take for granted. And I mentioned the second story because I want to emphasize how it is now more important than ever to establish immigration-informed practices wherever we are. And so the idea of immigration-informed care is something we developed that really builds on the idea of trauma-informed care. So to describe healthcare settings that are primed with the knowledge and resources to meet the health needs of immigrants. So we've already, in the previous sections of the talk, have heard about some of the principles of what trauma-informed services need to include, sort of safety, trustworthiness, transparency, peer support. And in addition to those core principles of trauma-informed care, components of immigration-informed care would include appropriate language services, so clearly delineated referral pathways for undocumented patients, clinicians who are trained to discuss sensitive topics without inciting fear, and institutional policies like the ones I outlined that ensure the physical and psychological safety of immigrant patients and healthcare staff. And I'm going to end by sharing 2 additional resources beyond the ones that I offered at my study website, which is doctorsforimmigrants.com. But one is a sanctuary doctoring toolkit that's created by some colleagues in Chicago. And the second is an additional toolkit that was just recently released by some of partners that I have worked with that focuses on additional policies to consider for border cities. And with that, I will wrap up and thank you, funders from California Initiative for Health Equity and Action, and please be in touch and really look forward to the conversation in the Q&A.
Thank you so much, Dr. Sadi, and we'll come back to having a discussion of your wonderful concept of immigration-informed care in addition to trauma-informed care when we return with the panelists. So welcome back, everyone. If folks can complete the poll, that would be great. So thanks for responding to the poll. As folks can see, about 70% of all of you have participated in a training about trauma-informed care, which is great. But a smaller number of you work at organizations that offer this kind of training. And an even smaller number, so about 30% have offered this kind of training, and about a smaller number than that, 13% engage in the kind of screening that Dr. Burke-Harris talked about, the screening tools that are available. So let me turn to the panelists and engage in some questions and answers. So let me start by going back. Again, we have multiple current events happening. Obviously, Dr. Sadi referred to all the immigration policies that impacted immigrant and refugee communities over the last 3 years. And then we had COVID-19, and now we have some of the wildfires here in Northern California. So let me go back to Dr. Quach first and just talk about how COVID, and especially the anti-Chinese racism, was experienced as additional trauma by some of the patients that you are seeing and serving in your community. Dr.
Thank you, Ignatius. Yes, so we have been seeing both in the survey that I shared that there had been higher amounts of people who have experienced this. And I would say that many of them, as you saw from the survey, were actually just holding themselves up in their house. So I anticipate that if they were moving around, that question of whether they experienced emotional or physical abuse or attacks would have been much higher. Based on what we were hearing from our own patients and our staff witnessing, we have seen cars try to run over people in front of grocery stores. Like, this is the type of trauma that they're experiencing from getting on the bus and being yelled at and to sit in the back, the microaggressions, and then the physical and traumatic experiences that adds to already the fear that many of them have experienced. And like we said, many of them are immigrants and refugees or children of immigrants and refugees. All of this triggers them to no end in terms of those experiences that they've had. we've heard from our senior patients sharing about, being inside their homes and not knowing when it's night and day because they're so fearful of going out. And when our staff have called up these patients, they were just so thankful to have an outside person speak to them. But this idea of having these attacks being blamed for COVID and then being ignored when it came to services because of the model minority myth is a huge problem for our community. It feels like we're launching two battles here. And I want to share some sad stories in terms of patients who have attempted suicide. Fortunately, none of them were successful, but this is what we see on the grounds. And being able to sound the alarm and be a solution and really raise those voices is the challenge that many of us advocates are facing right now, in addition to trying to get the culturally, linguistically, and trauma-informed care that our communities so desperately need.
Thank you. And so let me turn to Dr. Sadi, and stay on the COVID theme for a moment. And obviously, the public health practice is if people are exposed, that they need to self-quarantine or self-isolate at home. And for many people, that's a challenge that, again, their housing situation may not allow them to do that. They may be in family, multi-generation households. They may not have stable housing. Can you talk a little bit about how that in itself, just sort of those environmental issues, also create additional stress for immigrant and refugee communities?
I think the stresses are on multiple levels. So one is sort of the mental health consequences of just sort of being in isolation and quarantine, and is even more sort of severing social ties that are so critical for someone's mental well-being. So we see sort of increases in anxiety, depression, loneliness. There's also incredible economic strain. We've had, just even my clinic, people being either required by their employers to sort of prove through multiple tests that they can go back to work, or then coming in and asking us to provide letters because they want to go to work earlier than we would recommend, because there's such significant sort of economic strain during this time. And then I would say, just from a sort of a physical space perspective, just even with my clinic appointments, I have found it difficult for patients to have private appointments. I had an appointment with a patient who had to lock herself in the bathroom to be able to talk with me. And so she was sort of scrunched into the small bathroom, in her room. And other times I have families that have multiple children, or there are multiple people in the household who are trying to, be in school, trying to have doctor's appointments. So it can be really challenging in a small physical space. And I think all of these things we need to think about sort of in what we're seeing in terms of the immediate aftermath, and then also think about this, because some of these ramifications are going to persist over long time periods, for like the increases in anxiety, depression, loneliness.
Thank you. And Dr. Sheila, there were some questions in the chat from the attendees. Any tips or suggestions to help immigrants themselves explain this concept of trauma, which may not be something that they necessarily have heard about? How do we help parents understand that as something that their children may be experiencing? And then also, especially in the social media world where young people may be talking to each other, are there any tips for adolescents and young people on how they can talk about it among their peers?
So I'm going to address the two parts of the question, and the second part first by telling you that there are many resources, many organizations, professional organizations, and government organizations such as SAMHSA, the Substance Abuse and Mental Health Services Administration, that have a special list of resources for youth and peer support. So what I'm going to do is to post them in the chat, so for people to follow those resources, because there's a lot. And there are also community-based organizations targeting youth, and because there's such an important, they're taking they're leveraging the natural need for socializing among peers of youth to enhance that power to exert a positive influence, socializing influence. Now, in terms of the language and how to explain, that's a difficult, paradoxical, it's an easy and a difficult issue because fear and threat are universal. All of us have the experience, but the language and the way we make sense of that varies throughout the world and different cultures. So that's a challenge. So I think that my personal advice would be to stay away from clinical labels, including trauma, actually, until we are sure that the patients are understanding the same thing that we are. There are many communities and groups within those communities for whom even the word abuse is not something that they feel comfortable with. So whenever we are having conversations about these issues, or asking about, I would be very careful with the language. So be descriptive. So describing it, also introducing the idea that we have in the body our survival mechanism. We all need to stay alive by detecting promptly and responding quickly to threats in the environment. And the threats come in many guises, and that system is automatic and responds in a matter of seconds. Most individuals across cultures and languages have a sense of what the body does when it's under threat. So we have expressions like butterflies in our stomach in English, but there's multiple ways to convey that so people can find a common language around fear, the body responses to fear. And from there, from the body, help understand that there are parts of the brain that are deeply connected to everywhere in the body to prepare for fight, flight, or freeze, to describe the basic responses, and how our perception, how our mind perceives threat can trigger those responses, even in the absence of those actual threats. So last but not least, I think that is, in my experience, has been very helpful to use metaphors and proverbs or sayings. Most of my work has been with Spanish-speaking immigrants and refugees. And so that I go back to my first language is Spanish. So I know many sayings, popular sayings that people can quickly understand, grab what you want to say in a non-technical way.
Great, thank you so much. So Dr. Sadi, do you want to add anything to that?
No, I think Dr. Sciola did a great job. I don't have anything to add to that.
So I do have a follow-up question for you, Dr. Sadi. So we talked a lot about, obviously, the impact on children. Dr. Quach talked a little bit about the impact on older adults and seniors. There are obviously many diverse populations that are experiencing this. And so there's some questions in the chat about immigrants with disabilities, so that intersectional multiple identity. And also, I think the particular experience of immigrant women, when you talk about sort of that life course of trauma and violence that began in their home countries. A lot of the asylum seekers coming are women with their children fleeing various kinds of violence in those home countries. And so do you want to talk about immigrants with disabilities and immigrant women?
Yeah, so I think in terms of immigrants with disabilities, I think sort of linking to just people with disabilities more broadly, I think research in past pandemics have shown that disabled people find it harder to access sort of medical supplies during pandemics. And that can become even more challenging, right, as resources become scarce. So imagine in the initial sort of moments where there was a lot of fear and people were buying a lot of things in stores, that typically sort of disadvantages disabled people. I I think there's also a lot of policies and fears around rationing medical care that a lot of times intensifies a lot of discriminatory attitudes towards disabled people during times of crisis, and obviously can worsen anxieties about just getting sick and needing to get medical care and being fearful about what it might mean if you do get sick, and how a hospital might think about rationing medical care in terms of sort of, again, during times of crisis. So I think this goes sort of part of a larger point, which you alluded to, is that for some individuals, there's sort of additional compounded vulnerabilities that we need to be really attentive to. I think in terms of women who are in domestic situations that involve intimate partner violence, and again, even outside of the immigration context, sort of studies have shown that during times of pandemics, because people are more at home, there's sort of just, we see sometimes increase in substance use, that there's sort of more time at home with a potential abuser, that we see an uptick. And I know certainly that the hotlines that have released, you know, an uptick in calls that they've been receiving. But I think for immigrant women, what's sort of compounded in this context is that we've seen continued immigration enforcement that during the pandemic that has exacerbated existing fears in immigrant communities. And I just wanted to make, I know this was sort of not part of your question, but I'm just gonna add it anyway very quickly, but I want to sort of make a comment about sort of the protests and calls for racial justice that we've been seeing, and really the tragic police brutality that for a lot of patients that I care of have also worsened their trauma, because they have witnessed and been either themselves been subject to police brutality or witnessed it, and to see it sort of hit home in a very different way in a place that they thought they would, you know, be safe from, that has been really difficult. So I know that was not part of your question, but I just thought it was missing in the conversation, and I just wanted to make a point to that explicitly.
Great, thank you. Thank you for introducing that and integrating again, you know, that certainly the awareness of structural racism, as Dr. Hernandez alluded to in her introduction, and those responses are also a critical part of how we're developing these kinds of responses. So let me turn to some of the positive approaches that many of you have shared, which is really terrific, and Dr. Burke-Harris also shared. Dr. Sciola, I know you're trying to type some resources in. I really like the fact that you framed resilience in multiple levels, that it isn't just about individual characteristics, but it's also about the support, the networks, the community, the organizational resilience that we see in communities as well. Can you talk a little bit more about some of those organizational strategies or community level strategies to build resilience, to build a sense of self-advocacy and self-efficacy around some of these issues?
Thank you. I think one of the wonderful phenomena that has emerged in this country in regards to trauma and community and resilience is, I think, part of a long tradition in this country of community organization and helping each other, that interestingly in other countries that are more collectivistic are less, they're not cultivated as much, because the unit is usually a clan, a family, or a smaller group or church. But here there's a long tradition, I think, of being based in neighborhoods or locations. So there are many, everywhere there are many organizations that are springing up to disseminate the idea that communities can get organized to enhance and coordinate services and resources for resilience. As I said in my model, resilience is not only a capacity of an individual, but it's also their ability that we have to mobilize resources around us and for communities to provide and be responsive to those needs. One of the most successful that I'm aware of resources is called the ACEs Connection. Some of you may be aware, the Adverse Childhood Experiences, acesconnection.com, and they have built a platform organized throughout the country and actually now internationally, encouraging the emergence of local communities that organize around resilience. We have here one in Sacramento called Resilience SAC, and next to us another county is Yolo County ACEs Connection that is very active too. And so those are examples that I can think of off the top of my head. And based on this idea of resilience as an interactive process. I will stop there. I may add more things, but I want to give the opportunity to other panelists as well.
Great, thank you. And Dr. Koch, the response that you described at Asian Health Services to set up this testing and now enter into contact tracing, to me is an example of that kind of community resilience of finding those resources, building those resources, providing the information as well as obviously the testing that is backed up by obviously the medical staff and the health services that you can provide. So how have you at an organization like Asian Health Services been able to, in the context of this trauma, in the context of COVID-19, build that kind of trust or maintain that kind of trust? You talked a little bit about, you know, the inability to get people out of their houses. So talk a little bit about what you have done and what has seemed to work for you.
So I would say that because we've been around for 46 years and have built that long track record with the community, a very diverse immigrant, refugee community, that has gone a long ways. It's not just the trust, but that our 500 staff are actually hired from the communities that they serve. And I can't tell you how important that piece is, because really when you look at so many of the issues that we face, whether it's anti-immigrant policies, whether it is a pandemic, the culture trumps geography, the culture trumps so much. And so to be able to put out, you know, in the midst of fear, of stigma, that Asian Health Services is here for you, that we have opened a testing site, that we speak the language, it is with the providers that you know, it is the staff that you trust. You know, in the moment that we opened up, people who hadn't come out for testing, we had lines of people ready to come out. And that speaks to the trusted partners and the trusted sources, I would say. That, you know, I don't think we've changed too much of our mantra around culture and linguistic competency since we've opened, to understand that that is a heart of so much. And with that is not just language, it's not just culture, it's understanding immigrant and refugee experiences, the fear, the loneliness, the isolation, and then also seeing that their doctors and their nurses and their, you know, medical assistants are from the same communities that they're from. It goes a long ways. When we opened up the COVID helpline, which is an added piece to the testing, we were getting 200 calls that week of people just asking questions. So it's free, right? I don't have to give my immigration. I don't have to give my insurance, but they finally have a place that they can call and ask, because everything that's put out is either tied to the local government. And given that many of these immigrants and refugees come from places where the governments were the ones that attacked them, it's important to link it up to a community resource that they trust, that they know has been out there. And, you know, right now, as we're speaking, my staff are out there doing 200 tests, and people aren't afraid to show up because they know that Asian Health Services' name is attached to it. And that's true of Asian Health Services, but it's true of so many of the other clinics and community organizations, that we really have to lean on those CBOs who have developed those inroads. And particularly in times of crisis, we are needed more than ever to bridge that gap. We serve Asian Americans. I know that there are Pacific Islanders. I know that there are other immigrant groups that need it. And I think it's important to build on that infrastructure and to know what's really there. I want to get to a piece around how do we ask questions, because again, the bilingual and bicultural staff is not just language and culture. It is understanding the people. It is when my staff go through the questions that they have to ask to make an appointment, they will tell me too, that is going to trigger someone. That is going to make them hang up. And so we work around it. We say it's optional. You can provide this, but if you're uncomfortable, you can say something else and I will pass it through. It's important that we understand the people that we're speaking to and that we can let them know that they have choices and that we're not there to monitor them, that we're really there to help them. So I think it's really taking those approaches to serve the communities that we serve.
Great, thanks so much. And I think another observation that I made is the statistic that you shared about adapting to telehealth, that it was very minimal, and now it's, you know, the overwhelming majority of your visits. So there's that adaptation as well that a lot of healthcare providers have had to undergo. So let me turn back to Dr. Sadi. In your research, you looked at these kinds of policies and you have really helped frame all the different kinds of strategies that an organization, a healthcare provider, a hospital, a health system could adopt. Anything stand out for you? This puts you a little bit on the spot about a hospital, a health system that really seemed to do this well, that actually was operationalizing the kinds of things that you were recommending?
Yes, and I would at this point really have to elevate the work of federally qualified health centers, because they are, as Dr. Quach sort of alluding to, are so tied to communities and community partners and CBOs. So what I saw, you know, I went to 27 different institutions across 5 states in California, Texas, Illinois, Florida, and New York. And definitely the pattern that became evident was that FQHCs were sort of leaps and bounds ahead of sort of county academic medical centers and those connections to community organizations were so central. So at some of the other facilities, their first step was, well, let's connect to those CBOs because we need to get connected to the community. We need to know what, how to adapt our policies. We need to know what the trusted information to get out there is. So for them, that was their first point of action, right? So everything else followed several months later. Whereas those centers, and particularly the FQHCs, because they already had those pre-existing relationships, were able to hit the ground running. And so really, even just when Dr. Quach was speaking, I wanted to give her a standing ovation because it was just so spot on in terms of how critical those community partnerships are.
Great. And I think in every community, immigrant and refugee community, there are those counterpart organizations that have always been there. Some of them are formal, like community health centers, but there's going to be a lot of informal networks, faith-based networks and organizations as well that are often the first place that a lot of immigrants and refugees go. So let me turn back to Dr. Shiola. There's some good conversation in the chat about your allusion to using metaphors in one's own language, in Spanish, for example. Are there any other examples in which we can really tap into culture in a way that helps not only explain what trauma is and trauma-informed care, but also can use culture as a way of healing, as a way of also helping people through the trauma that they're experiencing?
Sure. I think there are a couple of general concepts that have been very helpful to me to understand and take care of refugees and immigrants from multiple countries, actually. One of them is acculturation, the whole field of acculturation, which is, can be a little bit technical at times, but in summary, I think that there's an consensus that acculturation is a process that can lead to better or not so good outcomes in terms at least of mental health. And one of the consensus is that becoming bicultural, it's better than not. So individuals who live a life in only among peers and trying to preserve as much as possible of the original culture in the host culture may not be the best strategy in the long term. And this is not a clean process, or it's full of it's messy process. But by and large, I think being bicultural and bilingual can help tremendously navigate this process, because cultures, by retaining some elements of culture, we can become more resilient actually than if we relinquish all that heritage and try to adopt blindly, if you will, the values and the mores of the host culture. So I often tell patients, think of a Chinese menu in which you have many offerings and you pick and choose what you really want. So you don't need to adhere to everything in the culture, but you can pick and choose. So that's one concept I think that has helped me, the acculturation, and the idea that you can become fully bicultural, bilingual. So the other, it also has to do with sociology and long-standing research, trying to understand why some cultures seem to be so different. The vast majority of cultures around the world are what is, they place such a value in the community and the family, as opposed to this extraordinary phenomenon in the history of humankind of Western Europe and its cultural satellites that privilege so much the individual and privacy and things like that. So that can, I think it's also a complex issue, because it comes with a gift, but also vulnerability. And let me give you a short anecdote about this. When I was working in a community clinic, a standalone community clinic, county contracted in northern Sacramento for several years, I had the honor to take care of many Mien and Hmong patients. And the county asked providers to once a year ask, what are in this client treatment plan, what are your strengths? And this, I fast forward after years and establishing a rapport with interpreters, we would laugh because we knew the answer to this question. Most patients were absolutely puzzled by this question. They have no concept of personal strengths. Their idea of themselves is their family, their community. So the strength, so eventually I worked around how to tap into those strengths, but through another door, if you will, by asking them about their family and the things that they value in their lives and want to preserve. So I think it's important to be mindful of this distinction between collectivistic cultures and individualistic cultures. And that's helped me to translate my messages. So one last point that I want to make is that in many collectivistic cultures, it's so important to preserve the order of the family that when a perpetrator is in the family, it becomes a very challenging situation to break that. And so providers can be, I think, more effective by being mindful of that. How difficult it is to, for example, confront a perpetrator or change the dynamic. The same token, I think we can do a lot of work by educating, and once again, helping modeling bicultural. This is, for me, has been especially important for sexual minorities, LGBT individuals, and women to be able to be assertive and selfish. I tell them, quote unquote, they say, Dr. Shola, that's not good to be selfish. I'm a mother. I need to worry about everybody. I said, well, there's something about self-care. You have to develop that part of you that may be not something that in your culture of origin was valued or considered. but in this culture, you have room to grow in that direction.
So thank you. Those are all great examples of ways that we can adapt the language and adapt the concepts and not necessarily use the scientific or the technical terms, but be effective communicators, which was the key on the bottom of Dr. Raha's pyramid of patient-centered care. So I want to thank the panelists for a terrific discussion and turn it back over to Dr. Hernandez for some closing observations and remarks.
Well, thank you very much. That was really an extraordinary program. I don't know exactly how you do standing ovation on Zoom, but from top to bottom, this program today has been absolutely rich with both, understanding, beginning with our Surgeon General's remarks, really understanding the basic biology and the biologic response to chronic stress and toxic stress. Really did frame very nicely the ongoing conversation that we had. My big takeaway from Dr. Burke Harris's remarks, I've heard her speak numerous times. I actually had the incredible opportunity to go online and to take the ACE training for clinicians in California. And any clinician on this program that hasn't done it, I highly recommend it. An incredibly useful tool. My big takeaway from her remarks, however, were that in the CDC definition of toxic stress and ACEs, the notion of immigration ought to be part of the conditions that lead to chronic stress. And I think that was a theme that ran through the entire program. Yes, abuse, neglect, parental separation, incarceration, domestic violence, and immigration. I think we heard her and our panels as well discuss. The program identified so many models and tools for clinicians of all types to be able to tap into. The one theme that I heard through all of the panelists, which was quite striking, is really the science of resilience. So it is not just about doing appropriate screening, but also about really building on the strengths of individuals, of families and communities and immigrants in order to really fully tap into the science of resilience and to build on it and to continue to use those that evidence as a treatment modality. Dr. Quach in her remarks, really just want to call out this whole concept of understanding our own culture and our own history. Striking that starting with Sergio, the Surgeon General, our speakers, all of us have a history of our own immigration and in our own cultural history. And it is important for us to be self-aware of that because that is something that helps us as clinicians be more sensitive to those that we are trying to serve and care for. I just love, Dr. Quach, your comment in the photos doing COVID testing, that your nurse practitioner there started off as a receptionist and then a CNA and then an RN and then now the nurse practitioner who pivoted to be able to do COVID testing and I'm sure soon contact tracing as well. I think that really does speak to community resilience. The notion that economic development and job training and getting people exposed to healthcare, Dr. Sadi's remark that 1 out of 5 healthcare workers is of some form an immigrant. And that story is such an important story about our delivery system and how it is trying to respond in COVID and respond more broadly to structural racism. And so I just found that to be incredibly beneficial. And Dr. Quach, as an epidemiologist, also the importance that you made in your remarks of being able to do research in a community-based setting. And then Dr. Sadi, I have to say, I had never heard of immigrant-informed care, and the way in which you have built upon trauma-informed care, and really to make it relevant to folks who are immigrants and are subject to so many acts of stress and violence, whether it's through policies or through practices, countries of origin, coming here, seeing, racism manifest itself in our police force in many cases. I just thought that the framework that you put together for an immigration-informed care was really quite extraordinary, and I learned a tremendous amount from your presentation. And lastly, just to say, Dr. Ciola, talked a lot about the notion of both systems and organizations and programs. And I think that's really important as we think about how we collectively work together to mitigate the stressors that exist by virtue of policy and or practice. But I think your framework and describing it so aptly that we really need to do this work at multiple levels. The Asian Health Service Clinic is a great example of a clinic having a mission, a pandemic breaks out, and it pivots to do the kinds of things that is needed to be done in the community. And in that way, this entire program was incredibly uplifting at a time when one might well argue that racism is in fact a public health emergency in this country, that the policies, excuse me, that are being promulgated, that we talked about at the top of the program, that really this is promoting racism. Dr. Quach talked about it in how she described it in the communities in Chinatown in Oakland at the outbreak of COVID. The president referring to the COVID-19 as the Chinese virus. I mean, this is all examples of the way in which racism is manifesting itself in our country. And yet what we heard today was really the resilience of immigrants, like all of those that were on the program today, to both do the research, to build the evidence, to put in practice, and to continue to learn and document and bear witness to what we're seeing today by virtue of the federal administration that has really promulgated toxic stress, not just on the specific immigrants, but on all of us as we bear witness to blatant racism. And so I just want to stop by congratulating and thanking Sergio and your team. Ignatius, you did an amazing job of facilitating with our panelists today. Quite an extraordinary program, a lot of resources for people to tap into. And I just couldn't have been more pleased at being able to participate today. And I want to thank the entire team that did all the logistics, thank our panelists. Again, really an extraordinary presentation by all of you. Thank you very much. And with that, Sergio, I will give the program back to you.
Well, thank you so much, Sandra. I echo all the things that you said, strongly echo that. So I won't repeat that other than just to let everybody know that, there is a lot of work behind the scenes, especially to so many people who you couldn't see, but nonetheless, they are the ones that make it possible to have a program like this. And in particular, I want to thank you, Sandra, for your support, for your commitment, for your wisdom and savviness about putting these topics, front and center. Really, really appreciate that. And of course, I appreciate all the speakers, in particular, our special guest, Dr. Nadine Burke-Harris, and also our three fantastic panelists, and Ignatius, what a wonderful job you did moderating. You know, not only the panelists, you know, but pulling the questions that came from those in attendance and those who sent questions ahead of time. One last couple of things more. I was very impressed as I was looking at the chat. What wonderful you know, questions, comments, resources that the audience posted. I'm very impacted by the level of engagement, meaningful engagement that this session brought up. So thank you for your engagement. We would love to see you again for the last part 3 of the symposium that you can see on the screen, which is going to be focused on financial impacts and policy solutions for trauma in immigrant families. This is going to happen on September 22nd. And as you can see, the panelists are Cynthia Buiza and Maria Elena Incapié and Jeff Hodge, which are going to share with us a kaleidoscopic view of you know, of a topic that is of critical importance. So thank you again. Please take care and be safe.